Are you ready to unlock your full potential and maximize your productivity? Look no further than Productivity Smarts, the ultimate audio podcast hosted by renowned productivity expert Gerald J. Leonard. In every episode, Gerald shares captivating stories, invaluable tips, and cutting-edge strategies that will transform the way you approach productivity. Whether you're looking to reduce stress, overcome overwhelm, or simply get more done in less time, Productivity Smarts has got you covered. But that's not all. You'll also gain inspiration from real-life success stories of individuals who have achieved greatness through productivity. Plus, you'll learn the latest tools, techniques, and habits that will help you achieve a new level of happiness and fulfillment in your personal and professional life. So why wait? Join us every week as we delve into the exciting world of productivity and help you unleash your full potential. Get ready to take your productivity to the next level with Productivity Smarts. As a productivity expert and host of the Productivity Smarts podcast, Gerald J. Leonard has been a proud supporter of Kiva since 2011. Kiva is a non-profit organization that helps entrepreneurs in third world countries access the capital they need to start or grow their businesses. By making a small loan through Kiva, you can help these entrepreneurs achieve their dreams, support their families, and contribute to their local economies. And with a repayment rate of over 96%, your loan can be relent to another entrepreneur once it's repaid, creating a ripple effect of positive change. So if you're looking for a meaningful way to make a difference in the world, consider making a loan through Kiva. With loans as small as $25, anyone can be a microlender and help change lives. Visit kiva.org to learn more and start lending today.
Well, good day, everyone. Today I'm speaking to Dr. Mauvareen Beverley. She is the president of Mauvareen Beverley's MD PLLC Patient Engagement and Cultural Competency Specialist. She is an executive level physician and a fellow of the New York Academy of Medicine with over 20 years of experience advocating for improving patient engagement and cultural competencies for all populations, especially African-American communities. Under her leadership as Deputy Executive Director of County Hospital, she led her team to implement innovative strategies to improve equitable health outcomes and decrease congestive heart failure readmissions from 30% to 18.7% in less than 2 years. Dr. Mauvareen Beverley is a powerhouse. So, Dr. Beverley, thank you so much for joining Productivity Smarts today.
Thank you so much, Jeff, for inviting me. It's an honor.
You're so welcome. Now, I have to ask you this question. Your name is Mauvareen. How did that come about?
Yes. So, my mom, who was the ultimate negotiator,
yes,
she had 6 sister-in-laws, and they wanted Maureen and she wanted Marva. So she combined it and made it Mauvareen. So, and then when you add Beverley to my last name, you know it's been a problem with my life. Mauvareen Beverley.
Right. They're going like, so Mauvareen, your last name, or is it your, like, is that your middle name or is it a nickname?
Yes, I have watched people write, what's your name? I say Mauvareen Beverley, and I watched them write Beverly Maureen.
Yeah. Exactly. Well, my name is Gerald Jerome Leonard, so I have 3 first names, and you can imagine I have the same issue. Mr. Leonard, or Leonard, Mr. Gerald, I was like, yeah, exactly. So, well, listen, you have a very impressive background, and I read your book, and you have some amazing insights, and you were really a thought leader in the medical industry, a medical field, especially in the state of New York and Queens. I lived in New York for a while. That's a tough place to be an expert, but you've done that. And what do you feel like has helped you to become successful throughout your career?
I think what I've done was a couple of things. To develop innovative processes within system.
Yes.
Like, give an example, I developed the first care management program in New York City Health and Hospital at Queens Health Network. Back then, no one was talking about care management. And inclusive of the care management process was the concept of the bridge team. And the whole idea of the bridge team was to bridge the gap. I don't care what the gap was to bridge the gap. Because the team would have a little extra time to speak to the patients and family and then communicate who they are and the information to the actual clinical team. And I think the bridge team was a really important process that caused me to look at it from a wider perspective. And why do I say that? It's a wider perspective. It is what I call these stop in my tracks moments that led to boots on the ground, simple solution. And they all came from patients. And one of the stop in my tracks moment is we went to see, the team was made up of care case managers, social workers, and myself.
Right.
And the team, we went to see this 18-year-old patient who had sickle cell. And, everybody was saying she's so disrespectful, attitudinal, always in the emergency room, and she's just, pain.
Right.
And I'm thinking, what 18-year-old is not attitudinal without a life-threatening condition? Let's give her the benefit of the doubt.
Right.
So we're about to enter her room, and she did, I'm on my phone, squirming her hand around, I'm on my phone. So we said, okay, and team is whispering, that's what we're talking about. So she finally got off the phone, and I was about to enter her room, and she said a very powerful statement. If you have a cure for my disease, come in. If you don't, and she pointed, keep walking. Was I expecting that Monday morning, 9 o'clock? So then I became the child and she became the adult. And why do I say that? Because her next statement was, did you hear what I said? I'm going to repeat myself one more time. Isn't that what we tell our children when they're not following direction?
Right.
If you have a cure, come in. If you don't, and she pointed, keep walking. So then I said, I don't have a cure, but let me think about what you said, and I'll come back and see you. And what was really interesting, Gerald, the person who I met that morning was who the system created.
Yes.
The person who I met at 5 o'clock was who that actual individual was. Very smart, very thoughtful, and very thought-provoking. And I asked her about her family. And she said at 16, her mom got off the bus, developed a chest pain, got taken to a hospital, and died of a heart attack. At 17, her sister, who also had sickle cell, was admitted to a hospital with sickle cell crisis and sepsis and died.
Right.
And now she's 18 and she lives with her uncle. And the way she describes it is more of a food, clothing, and shelter type of guy. And I said, and she said another powerful statement. She said, you doctors don't teach me about sickle cell. Sickle cell teaches me. And I said to her, have you ever been referred to counseling? No. Have you ever been asked to referred to a therapist? Have you ever had depression screening? And she said no.
Right.
And it was what I call the stop in my tracks moment that caused me to go straight to the emergency room, met with the emergency room director and said, we have to change how these particular patients are treated. And what I want to do is to start the first sickle cell support group for adults.
Right.
And what happened when the patient came in the hospital and the emergency room, then the care managers would ask them, do you want to join sickle cell support group?
Right.
And then they would sign them up. And we ended up with about 16 patients, and we had it at lunchtime, and we provided lunch an hour before hematology, and it was once a week. And I tell you, when you heard some of the stories, it was humbling. And I heard the term hate a lot. I hate my mom. I said, oh my God, why do you hate your mom? And she said, oh, I don't hate her now. I know she loves me over the moon, but I never understood when I was younger, why did she side with the doctors to keep me in so much pain? Why didn't they just let me die? And then another member of the team said, my brother hates me. I said, why would your brother hate you? She said, because I suck up all the oxygen in the room. She has sickle cell and he does not.
Right.
And so the brother was on a basketball team. The team never went anywhere. All of a sudden, they made it to the semifinals. And let's say the finals is tomorrow. Mom and dad and her were going to obviously go and support her brother. And she developed sickle cell crisis at 1 a.m. And the mom and dad had to take her to the hospital.
Right.
And that's when I recognized that there's no family counseling offered.
Right.
And so these are some of the points that I learned from the sickle cell support group. And why do I think that's important? Because now I did research to find out about family counseling. And there's none. When I call different hospitals, do you have family counseling for patients with no? They don't.
Right.
And what happens is in terms of the community, what I think was important is in terms of the way I see it, when we want to create health equity, it's not just to create it for a point in time. I want it to be sustainable.
Right.
Because if it's not sustainable, it's going to fall by the wayside. Exactly. And I'm happy to say that the process of the sickle cell support group at the hospital is still operational to today. Now they do it by Zoom because of COVID and everything. Now they do it by Zoom.
Right.
So that's my focus on sustainability of a process that we're going to put in place to achieve health equity.
Exactly. And, it's really interesting. And I have to say this too, for those who are listening, you might wonder, why are we having this healthcare conversation? And it's because, one, if our health is not taken care of and we're not being advocated for, or we don't know how to advocate for ourselves, our productivity will be shot. As I went through my own challenges with health that drove me to do this podcast and develop this concept of productivity smart, it was dealing with a major health challenge where I was able to advocate for myself, but also realized I needed counseling, I needed therapy, I needed doctors, and I needed that input. And it's so important that either you've dealt with a health issue, you've just come from a health issue, or you're going to be going to a health issue. So hopefully we're all kind of listening up and perking up our ears, because Dr. Beverley has some really great insights. She's implemented some really amazing, innovative strategies. And I love the concept of boots on the ground. And this, just to be honest, this topic hits close to heart. I have sickle cell trait, and I had a brother and a sister that had the full disease that have passed away. So I can emotionally and mentally relate to everything you're saying, and even that introductory story, because I can remember watching my brother and sister go through those health crises and the impact that it had on our family. And so I think this is a really important topic when it comes to productivity, because if our health is not there, then there's nothing else that's going to work. So thank you for sharing that.
In terms of sickle cell, we just have to everybody needs to be aware of the word drug seekers.
Yes.
And it's negative language towards patients with sickle cell. And it's the myth and there's reality. Right. The myth is that they're drug seekers. And the reality is that they're least addicted and the most vilified for individuals who require pain management.
Right.
And that's in the medical literature.
Right.
And so when somebody views someone as drug seeking and they come back to the emergency room, it's not that they come back for drugs. It's because it's been proven they were undertreated the first go round.
Right. And they're in a lot of pain. And I've personally experienced the level of pain that those patients go through by watching it happen in my own family.
Yes.
So I can definitely relate to that and understand. So let me ask you, because you've actually covered my question around what's misunderstood. So thank you for doing that, because that was preemptive. I was going to ask you that question, and thank you for sharing that. So one of the things I want to ask you is, in your book, and her book is The 9 Simple Solutions to Achieve Health Equity, you discuss various barriers to health equity. How does these barriers directly impact an individual's productivity in their personal and professional life? And remembering, I want you to speak from your perspective, because again, these 9 solutions that you've created were given to you by the patients themselves. So how would you answer that based on that?
So what I found in terms of the 9 solutions and productivity for individual, it really comes down to the understanding that there is a lack of human value, particularly as it relates to African-American patients.
Right.
And you hear that, and when you think of the atrocities that the elderly Black population have endured, and that they have the worst health outcomes in all disease categories, it's not the patients, it's the system that creates an environment that does not value these individuals.
Right.
And I say, when I do presentations, and I said, and this is because I spoke to patients, and I'll just give you an example. And went into this in Brooklyn, New York, and there's what I call the merging of the African diaspora. There's a large Caribbean population, a large African American population, and the Spanish population was from Panama.
Okay.
And under colonial rule, the British sent the English-speaking Caribbean to Panama to build the canal.
Right.
95% of the cohort of patients or individuals in New York are from the Carolinas. And I'm saying, why is everybody from the Carolinas, Virginia sort of down the street? So I have to go back into the research. And it's after the Emancipation Proclamation, when Blacks had their first representation in Congress, their community started to do better than the white community. They built schools, they built churches, they built businesses. The plantation owners' property went south because nobody was picking the cotton. And over the course of time, the Ku Klux Klan came in and burned the whole place down, and they came up the coastline to New York. And there's even a documentary, The Wilmington Massacre. And so from a cultural perspective, I think is important is what I call the lookalike syndrome, And so we have to be careful because we look alike and we're from the same location. We have to understand the unique cultural differences from individuals, and is what I call. And the reason I came up with that concept is when I was at Queen, the team went in, it was an Indian patient who was in the bed, and one of the team members said, oh, where in India are you from? And he said, I'm not from India. I'm Caribbean. I'm Guyanese, And is what I call the lookalike syndrome. I said, I just forget the cultural competence mindset is. And again, it came from experience. So I would say, go tell a British person they're Irish and see how far you get. Go tell a Chinese they're Japanese. Go tell an Indian they're Pakistani. Go tell a Jamaican they're Trinidadian. Go tell a Nigerian that they're Ghanaian. And most important, go tell a New Yorker that they're from New Jersey and see how far you get.
You will have a fight on your hands if you do that.
Yes. And so in Brooklyn, because of the merging of the African diaspora, it was important to know. So in the morning, because of the congestive heart failure readmission prevention program, which I was in charge with, when Medicare and CMS came in, if you get readmitted in 30 days, we'll only pay for one admission. Whereas prior to that, they would pay for 2, 4, 6, 8, 10. And all institutions across the country had to create a system to decrease the readmission, if for no other reason than finance.
Right.
And so my team was multidisciplinary and multicultural. We had on the team, we had individual African Americans, Caribbean, we had individuals that were white, individuals from Africa, and we had a city Jewish pharmacist on the team. And I tell the team, when you go in, ask the person, where are you from? And the reason I think it's important, I need to know from a medical perspective, are you visiting New York and you got sick, or do you live here? Because the transition of care would be different.
Right.
So again, I'm stopping my tracks moment. I went in, and this always seemed to happen at Monday morning, 9 o'clock. So I went in to see her, and I said, oh, good morning. She's 80. Where are you from? She said, South Carolina. And my next question was going to be, do you live in New York, or you visiting New York and you got sick? And her statement was, my parents were a step away from slavery and my grandparents were slaves. Was I expecting that Monday morning, 9 o'clock? And I said, tell me about it. And some of them spoke in codes. My family picked cotton on a plantation that was not ours. And then I had to get up at the crack of dawn and pick 300 to 500 pounds of cotton. And it was the same amount of cotton that was in that movie, 12 Years a Slave. Right. And then I had to walk 10 miles to a segregated school. And I'm thinking, 10 miles? We can't even go 5 blocks without calling an Uber, And then she said, I said, how did you walk 10 miles? And her body language changed and everything, her tone. She said, well, if you wanted education, you had to. Like, what part of this don't you get, stupid? So I said, did you have to walk back? And she said, no, the principal in the horse-drawn carriage took them back, and they had to get back before dark, before the Ku Klux Klan. I said, how old were you? 10 years old. Could you imagine?
Wow.
10 years old. She continued her education, went to Voorhees College. It's a 2-year black college in South Carolina. And this is now, she's 80. This is almost 60 years later, or maybe 50 years, 40 years later. Guess what her next statement was? I didn't get in till my second try. She was still upset with herself that she didn't get in. She came to New York, married. Right. Most of men in New York in the 30s and 40s were in the subway system. They worked in the subways, transportation, maintenance, so they were doormen. And I don't know if you ever heard of Stuyvesant High School.
Yes.
Her two children were 2 of 5 black children to integrate Stuyvesant High School.
Right.
She continued her education. Yes, which was amazing. She continued her education. She became a dietitian. I said, do you mind me asking you, when did you retire? She said, in 2000. I said, do you mind me asking you how much she made? She said, $200 a week, but others made more. Read between the lines. Right. And then, interestingly, I said to her, you're going to need home care. And her response, I don't want anything that's not mine. She thought I was giving her a handout. And I tell my team, if whether you meant it or not, apologize, because you are not in that bed. Apologize and say, oh, I'm so sorry. Maybe I didn't explain it the best way I could have.
Right.
But I said to her, everyone who has Medicare, and I didn't say entitled, everyone who has Medicare has home care.
Right.
And she said, everyone? And I said, yes. She said, okay. And that's when I realized that these individuals that are in our hospital beds are not included in the cultural competence conversation.
Right.
And the role of religion. And so, I make these presentations and I say, when a Holocaust survivor comes in the hospital, we roll out the red carpet. The chief medical officer, the board of directors, the CEO, the rabbi will go and see that patient. And so they should, because of the horrific circumstances that they endured. But when an elderly Black patient who is admitted to a hospital, how come we don't roll out the red carpet? And it's an opportunity to recognize and treat all atrocity survivors the same, and to recognize the role of religion in these two populations were pivotal to their survival. And we heard a lot of story about religion, in the hospital, because it was just humbling. And that's just one of the stop in my tracks moments that I mentioned.
Right.
And that's why I created that they're in our hospital beds and not in the history books. And the role of religion. And the patient was very upset and very sad. And she stopped participating in her care. And she was depressed. So they said, oh, we have to call psych and do a depression screening.
Right.
So I said, yes, part of the protocol, but find out what church she goes to and call the minister and let me speak to him. Because if the minister comes in and prays with her, what she's going to say no. So I found the minister, what she was most concerned about. And I asked her, that's the question, remember, I ask patients when I'm not sure, and not what I think should be important to you. I said, what is important to you? Let me hear it from you. And she said that I will not be, this was a Wednesday, that I will not be going to church on Sunday. Mm-hmm. So she was very upset with herself because she thought she wouldn't have felt guilty that she wouldn't please God. The minister came in and he prayed with her. Right. And Gerald, and after that, she was a different woman. And she went back to participating in her care. And he said, even if you're not discharged on Sunday, I'll come back and pray with you.
Right.
And, and that's when I realized these moments that we have to include the cultural competence for everyone in this population, particularly this population.
Exactly. And it's so important. I just came back from a week vacation and a kind of a mix of weekend vacation and business trip to Toronto, which is a very integrated, city. Yeah. It's very diverse, very culturally diverse. And it was amazing the number of people where if you do a tour or something, my wife and I were on a boat, and the gentleman who was narrating the topic was from Scotland. A couple of the boat hands were from the Philippines, and someone else was from another city, and so on. And, it's so diverse, and everyone has their own history and culture and experience. But yet when we find ourselves in a place where we're around people, even if they look alike, i.e. Americans or Asians or Spanish or whatever, they're from different parts of the world, they have a very different experience. Exactly. And so it's really critical, even for, whether it's your own personal life, your professional life, how we integrate with each other, that we become, I think it's curious. I think that's the word, that we become curious and interested, right? By asking, and that's really what you were doing, is that you were asking questions, because now instead of saying, well, I'm going to share my expertise and tell you what you need to do as a doctor, I'm going to become curious and ask you, well, why is that important? Or where did you come from? Or why do you feel sad about this? And then you realize that she was feeling guilty that she couldn't go to church, or that she was going to miss church, and she would feel like, I'm letting God down, or I'm doing something wrong, because she was physically not able to, but yet she still needed that care. And I think it's so important with our teams in business and in personal, whether it's professional or amateur, that we become and remain curious and inquisitive. And like you said in the beginning, and that as you begin to address this particular patient, one of the things when they made a comment, you said, I'm sorry, right? There was nothing you did wrong, right? But you wanted to put them at peace and also remove their barrier of resistance. Because if they're resisting you, then they will not be engaged in their healthcare and they will not be open to your influence. But if they realize that you are there to support them and you're sensitive and empathetic, then they're going to be more open. And really, you know, I talk a lot about neuroscience, and that idea is that you're engaging their frontal lobe and you're creating these positive neurochemicals that allow them to be open to experimenting and being more engaging, where if you would have pushed back and been a little bit more hardline, you would have activated the amygdala and their bodies would have been filled with cortisol and adrenaline. And then they're pushing back and saying no. And it's even harder to move someone, influence someone, or move a team of people forward by doing that. And so I think a lot of the strategies that you're sharing are ones that disarm people and gets them to be more open to experimenting and thinking through how to advocate for themselves and be open to your influence as an expert, as a doctor.
Yes, no, thank you. No, absolutely. And one of the concepts that I created was the concept of the common thread, the human experience.
Right.
And when I do presentations, I said, I did it at one of the health systems in New York. And I said, what is the similarity between a homeless person and a millionaire? And everybody, the intern in front of me said, look, like, really, lady? She said, the only thing I could think about is that they're males. I said, there could be females too, but that's another story.
Right.
So I said, but what is the common thread? Irrespective of race, gender, ethnicity, social economic status, country of origin, religious beliefs, language spoken, once accurately diagnosed, there's no human being on planet Earth can give it back.
Right.
The millionaire can't say, oh, I'll give you $1 million to take the cancer back. Oh, that's not enough. I'll give you $5 million. Irrespective of whether you're homeless or whether you're a millionaire, this is the common thread. Exactly. And maybe hospitals could be more empathetic and less judgmental, and to recognize the bulk of us taking care of patients never laid in a hospital bed.
Right.
And those that have done so are women delivering life. Maybe in some cases, patients are trying to prevent death. So if we have choices in life, if you don't like the school your kids go to, you could change. If you don't like your job, you could leave. If you don't like your family, you could move to another state. You have choices. If you buy something and you could return it, but there is no entity or no culture that says, well, in our culture, we don't accept diabetes, So the common thread is the unifying force. And if maybe we could all agree on that in health system, then we could be more empathetic and less judgmental.
Exactly. It's very well said. So let me ask you a couple more questions before we conclude here.
Sure.
So one question I have is thinking about the workplace, because again, I believe that health is really important. And many times we find ourselves in the workplace dealing with health issues and we don't want to be seen as having those issues, but they're real and they affect us. So this question is around the idea of, in workplace environments, they play a significant role in our individual health and productivity. What are some strategies that a business could implement to promote health equity and consequently enhance employees' productivity? In other words, what are some things that the hospitals, or if you work at a hospital or a organization or a business, could do to help advocate for health equity?
Number one thing would be eliminate the word non-adherent or non-compliant without asking why question. So we have gone from health disparity to health equity is a nicer word. We went from non-compliant to non-adherent, but you don't hear the why. And I think health systems will do the best if you don't know why somebody didn't do something X, Y.
Right.
We're trained in medicine to ask why, to do no harm, to the Hippocratic Oath. But in terms of differential diagnosis, we will need to know why the fever, why the headache, why the abdominal pain, why. But when it comes to a patient not following directions, we don't ask why. And it's been proven that in the medical records, more negativity is in the medical records geared towards Black patients, particularly Black males. And I'll give you an example how we were able to change this man's life. 60-year-old African-American male, recently diagnosed with congestive heart failure, returns 2 weeks later, heart failure decompensated due to noncompliance. So you think when that patient goes up to the unit, anybody's going to care about him? And what did the nurse on the unit said? Not on my team. Well, he just got diagnosed with a life-threatening condition and don't follow directions. I got other things to do. So then we had to ask why. Why don't you take your medicine? I can't take the water pill, which is a diuretic that flushes fluid out the body, essentially, right, so that the heart could pump better. Why can't you take the water pill? And I'm glad, Gerald, you're sitting down when I'm going to tell you his answer. I can't take the water pill because I drive the number 7 train. So you can't say, oh, the driver can, the train is delayed, the driver has to find a bathroom.
Right.
So we said, when is your shift? 11 p.m. to 11 a.m. What do you do when you get home? I do some chores, I take my medications, I take a nap, but if I'm going on my shift, I don't take the water pill. The same cardiologist who also ignored him brought him in and said, okay, take the water pill when you go home. Be aware it may wake you up during the day, but by the time you get to your shift, you'll have less of a reason to urinate. But to the degree that you do, we're going to give you a cubicle to take with you in the private space. So when the train stops, if you have to urinate, you can.
Right. Simple
solution. So guess what the patient said? If I knew I had to choose between peeing and breathing, I would have chosen breathing. Now, just expand the conversation without the why question.
Right.
Which saved him, he would have been readmitted multiple times. And
right,
if he were to pass, it would have said in mortality died due to noncompliance. So we don't want patients to have to choose between their health and their jobs.
Right.
And that's really what the situation he was in. And he had to figure out what's the better way. And I'm just saying, just a simple solution, not only it saved this man's life, but it also gives him the opportunity to continue to his job, continue the work that he has to do. And he doesn't have to choose between one or the other.
Right.
And when we asked why, it was so many examples of the why question. And just another thing that you don't find in medical records are patient fears.
Yes.
And you could see how patient fears could possibly lead to noncompliance, right?
Sure. No, but when there's fear there, the amygdala kicks in, and I always kind of equate it to what a dog does. They put their paws down and go, I'm not going. You're not taking me on that walk. I'm afraid. And we do that the same way as people.
Yeah. Just and that's when a learning curve from patients. This patient refused dialysis for 3 months, kept on, but went to every ambulatory care appointment. He was admitted, and I'm saying to the team, does anybody speak to his wife? Does his wife come to visit? Yes, she comes every evening at 5 o'clock, after work. So I said, did anybody speak to the wife? Because if anybody's going to convince him, she's going to be the person that would convince him. So I waited until 5. I went back to speak to her. And I said, I know you love your husband, but his kidneys are really worsening. And if he doesn't accept dialysis, he may not be here with you much longer.
Right.
And her next statement just blew my mind. She said, I don't think I want to do that. And I'm saying, what? To myself? So I said, again, tell me why. She said another powerful statement. I don't think I could live with myself. That's a very powerful. I said, tell me why. She said, because our neighbor down the hall went on dialysis and 2 weeks later he died. So could you imagine what you hear the statement? I don't think I could live with myself. Could you imagine if that happened to her husband? So we brought in the nephrologist. And again, what I was able to accomplish, to be honest with you, Joe, and I'm really proud of that, is to change the mindset and to change the culture with staff that we were dealing with.
Right.
And basically, the nephrologist told her, I don't know why your neighbor passed. He could have had a stroke, could have had a heart attack, or the kidneys might have failed. But one thing I will tell you, if you agree to dialysis, I will be there with you for the first week. How many nephrologists end up going to dialysis for the patient? So I'm very positive about the fact that we could change cultural norms. Right. And the other thing that I've done is what I do, perception reality. The same question that I ask the staff is the same question that I ask the patient. Okay. And if you design a system based on something that's not real, it's going to fail. A quick example, why don't patients take their medication? The average heart failure patients are taking 5 or 6 medication with comorbid condition. Why don't patients, I asked the ED and I asked the inpatient clinical team, including social worker, why don't they take their medication? The top answer was cost. And then one of the doctors said, well, if they can't afford it, what do you want me to do? Call the social worker. What if I told you that if I asked the patient, not one patient mentioned cost? So you know what the top answer was?
What was that?
We don't take our medication because we think we're taking too many medications. So if you're designing a system based on the perception,
yes,
and not the reality, so how we were able to solve the problem, we brought in the pharmacist to meet with the team. Can we combine some of the medications, the diuretic and antihypertensive? Does an 82-year-old person still need to be on statin? So we did look at all the medication and try to lower the amount of medication where possible, where the patients were treated. Right. And that also changed the dynamic. And it was just, so I look at it from, and most people don't do that. What is the clinical team on the hospital system thinks about this problem, and what is the actual patients who are in the bed think about that problem?
Exactly.
And if we're on the same page, good. But if we're not, it's an opportunity to learn from each other and put in place a system that's inclusive of both the reality and not the perception.
Right, right. I love that idea of the reality and not the perception, because in so many parts of our life, and it can be used not just in the medical field as you're using it, but in every major project, every major activity, every family interaction, that there is there's that two perspectives, right? There's the reality of what's going on in the situation, and then there's the perception. And what's interesting about a perception is that every individual has a different perception of what's going on. Right. So there could be, if there's 5 people, you have 5 different perceptions, but there's really only one reality of what's really going on. And the way you address that, which I love the simplicity of it, was you ask the medical staff and the patient the same question to see what the answer would be. Obviously, if the answer was the same from each person, then you know you're dealing with reality. But if the doctor said one thing and the patient says something else, then the reality is being missed. And so by bridging those gaps, you're able to combine that and really get them to get to the root of the issue and to identify that. And I think so many of us can use these principles, again, not only just in our health, but in our life, towards our goals, towards all the things that we're dealing with. Dr. Beverley, this has been a really engaging conversation.
Thank you, Gerald. I just want to add one more thing.
Yes.
On the non-compliant, and I tell patients, this is patient instructions for patients. If you go to the doctor or you're in the hospital or wherever you are, and you ask the question, did you take your medication or did you follow directions for something else? And you say no, wait a couple of seconds. If you don't hear the why, say, do you want to know why I didn't do something? And please don't write non-compliant in my medical records without asking me why, because it could affect my health outcome. And those are instructions I want to give the patients to be able to communicate about what their issues are.
That's a really good one, even if you're not going to the doctor, but you're talking to your boss. And they ask you a question, you're like, no, I didn't do it. And you wait and you go, do you want to know why? And then, okay, now we're having an educated, engaging conversation. Obviously, this would be a great healthcare question, and it can elicit a lot of deep dialogue between you and your healthcare provider, but it also can be a deep question in relationships as well as in your professional life. So again, Dr. Beverley, thank you so much for your insight and your wisdom. If my listeners want to get to know you and learn more about you, where can they go?
If you go to my website, is lowercase Dr. D.R. Beverley. No dot after doctor, just D.R. Beverley, .com. And my email address is mbeverley, BEVERLEY, M like in Mary, D like in David, @gmail.com.
Excellent.
And I'll be happy to have a conversation. But check out my website, drbeverley.com, because it also will give you an information of how you could purchase my book.
Yes.
It's on Amazon. And I just wanted to add, it was the #1 bestseller in newly released books. My book was released on Juneteenth, it was the end of slavery, federal holiday, and it was my birthday.
Oh, excellent. Excellent. And the book is 9 Simple Solutions to Achieve Health Equity.
Health Equity, a guide for healthcare professionals and patients.
Excellent. Excellent. Thank you so much for joining the Productivity Smart podcast. And I'm sure our listeners are going to get a ton of insight and wisdom from our conversation.
Thank you so much, Gerald. I'm much appreciative. Thank you so much for giving me the opportunity to have this conversation. And you have a great rest of the day. And thank you so much again.
Thank you. If you're enjoying the content and finding it valuable, we would appreciate it if you could take a moment and leave us a review. Your feedback is important to us and helps us reach a wider audience. If you leave us a 5-star review, it would mean the world to us. Not only does it help us improve the podcast, but it also helps us attract more sponsors and grow our community. Thank you again for your support and for listening to the Productivity Smarts podcast.
Thank you for tuning in to Productivity Smarts, where we help you achieve your goals and live your best life. We hope you've gained valuable insights and actionable strategies to boost your productivity and increase your happiness and fulfillment. Remember to apply what you've learned and keep striving towards your goals. And if you haven't already, be sure to subscribe to our podcast for more inspiring episodes and expert advice from our host, Gerald J. Leonard. Until next time, keep pushing forward and unleashing your productivity smarts.